आप नहीं करेंगे।
Which I Can you see my screen, full screen?
Yes, ma'am, we can.
Okay. So today we'll be talking about immunization schedules and what are the regular practice. So, vaccine preventable diseases is very important because data from worldwide, it says that one child dies every 20 seconds from vaccine preventable diseases. And why vaccines? It has been seen that it is recognized as one of the top 10 most effective public health interventions. So if you look at the top 10 public health 1900 to 1999, you see there are many things here: healthier moms, safer workplace, decline in deaths from coronary heart disease, family planning, etc. But vaccinations, and control of infectious disease are something which is a landmark achievement in this 1 century. Before we talk about the vaccination schedule, just two important terminologies. One is vaccination, which is the act of introducing a vaccine into the body to stimulate the immune system. And the second terminology which one should understand is the process of immunization. So actually, immunization is a process by which a person becomes protected against a disease through vaccination. So what are the goals of immunization? We have many long-term goals. Among them, the first and foremost is elimination of disease. So can anyone tell? I mean, we'll try to make it interactive. Anyone tell what is which type of disease has been eliminated? You can unmute or maybe just put a message or something. Then the second is decrease in transmission of infectious disease. And third is eradication of an offending agent. So eradication, we know smallpox has been eradicated. Decrease in transmission of infectious disease. The biggest example is COVID-19. And elimination is, one example is the elimination of maternal and neonatal tetanus in India. But the most immediate goal of vaccination or immunization is prevention of disease. So if you talk of people, it's an individual one-to-one prevention. And in groups, you could take a group, say elderly population. You want to prevent, say, herpes zoster in that group. So that will become an immediate goal. Now, what is needed to achieve these goals? First is timely immunization in all the age groups, whether it's infants, children, adolescents, or adults. Second is not only timely, but there has to be a consistent high level of vaccination, continued throughout the year and for many years together. Third, and another important aspect of immunization is intensive surveillance, which is intensive surveillance for the disease, which is vaccine preventable. And therefore, the second part comes in the effective public health disease control strategies. So in case you have a disease which breaks out, say you have a measles outbreak and you have done a surveillance and it has come to notice, then how quickly and how soon we can have a control of that measles outbreak will determine how effective our public health disease control strategies are. So how do vaccines work? They are said to prevent about 2 to 3 million deaths per year, and they save billions of dollars in healthcare expenditure. So let us take a simple example of the typhoid vaccine or the disease enteric fever. So in case a child is given a vaccine, the cost of the vaccine in Indian rupees will be around 2,300 to 2,500. But in case the child doesn't get the vaccine and gets the disease and has to be admitted in the hospital or maybe on an OPD basis, the expenses would range from nearly 30,000 to more than 1 lakh, depending on how sick the child is, what are the complications, how long the patient has to stay in a hospital, whether it's a public hospital or a private sector hospital. and so on. So you see, simple 2,500 would escalate and go up to 30,000 or maybe in lakhs. And in addition to that, we do not think about the other losses. That is the loss of the work days for caregivers, that is the parents, or in an adult, it would be the patient himself or herself. So if there is loss of work days, and particularly if this happens in the private sector, then it means there is loss of wages and therefore another economic burden to the family. Now, have we really done something amazing giving vaccines in the past century? So let us look at data. CDC is the one which maintains data very well. And this is from the Red Book of CDC. You see, they have maintained very good data. So if you look at the pre-vaccine era annual estimates of diphtheria, it's around 21,053. And in 2020, it's only one case. So this is a more than 99% reduction in the cases. Similarly, for hip, also it is more than 99. For few diseases, it's 100%, like paralytic polio, congenital rubella syndrome, and smallpox. And the other conditions are also not bad in their country, excepting for Hep A, which is around 92, and invasive pneumococcal disease, all ages, is only about 81%, whereas the invasive meningococcal disease in less than 5 years is nearly 97%. So this goes to show that vaccines really do work, and they are a great boon to the community. Now, what about the Indian data? Has India achieved anything as far as the vaccines are concerned? So if you look at the Indian vaccine story, this is nothing less than amazing. Look at disease, smallpox. In 1975, the cases were around 24,000. Post 1976, the cases are zero. So we have achieved 100% decrease. Similar is the case of polio, 1985, nearly 1.5 lakhs. From 2012 onwards, we have reported zero cases of polio. Again, 100% achievement. Neonatal tetanus has, again, there is a 99% reduction. Overall tetanus is around 97% reduction. This is comparison of data from 1990 to 2023. And diphtheria, which was in 1980 about nearly 40,000 cases, came down to 3,133 in 2013, so a 92% decrease. But you see in 2024 January, the numbers are high. So this is, again, the percentage decrease has gone down. Now, this has probably happened because this is a post-pandemic area, and we know very well that our immunization schedules got disrupted during the 2 years of the COVID pandemic. Similar is the case of measles, with a huge surge of measles post-pandemic. And in 2023, we had around 65,000 cases, which had actually gone down to 14,000 in 2013. So again, this data looks, it is very evident that we have a gap here because of the COVID-19 pandemic. Therefore, there is a continuing need to vaccinate as per the recommended schedule. So when you talk of schedule, why is scheduling done? The first and foremost reason is you want to achieve maximum effectiveness of a vaccine program with minimal healthcare system interaction or interference. That means you do not want to overburden the healthcare system by adding something new and then therefore affecting the efficacy of the previous program and even the new one. So we have to do a minimal interference in the existing healthcare system. Now, the decision on scheduling is always based on epidemiologic, immunologic, and programmatic aspects. So epidemiologic means what is the disease prevalent, which are the diseases more common in our country. Immunologic is how the patient responds, and programmatic aspect would be how we can include it in the program, club together vaccines so that, the patient has to come less to you for less number of visits, or you are spending less resources in achieving the maximum output. So cost effectiveness, safety, and effectiveness are the key factors for introduction of any new vaccine in an existing health program of the country. Now, in our country, we know that the public sector has less vaccines compared to the private sector. And This is so because in the public sector, the decision on introducing vaccines are based on many reasons. And one is the programmatic aspect, the epidemiologic and the immunologic. So therefore, a lot of debate goes on in the mind of the practicing pediatrician on which is the best schedule to be used and what should I do about it? How do I go about it? Now, if you talk of an ideal immunization schedule, it means that that schedule should induce an appropriate immunologic response at a minimum age, but we may not get 100% response. So an optimal response is enough for us, which is good enough to give effective protection, which is acceptable for the community. Then the epidemiologic consideration I've already mentioned, for who is the person susceptible for infection and disease. Now, infection is different and disease is different. So you may be infected with an organism, but you may not get the disease. Then second is how severe the disease can be and whether it leads to an increased mortality. For example, pneumonia vaccine was not introduced in our schedule for a long time, and it got introduced a few years back. Though we were susceptible for infection, though our patients were having disease, and the disease do get very severe, and we had a high incidence of mortality due to pneumonia, but the decision to introduce it came a little later because of the programmatic issue. One in the programmatic is whether we can deliver it with the other scheduled vaccines. Second is whether the cost of the introducing the vaccine is good enough that the country can bear it. Because in the public sector, it means you're vaccinating a huge number of people and the expenses goes up, escalates to a huge amount. Then what is the minimum age of the first dose of vaccine? Now, this is dependent on the disease epidemiology. So the protective immune response must be achieved prior to the most vulnerable age. Second is the immunological response. So we know that in the younger age group, the immunological response is less or limited, and therefore a later age is always better. But in some conditions, we cannot wait for a long time. For example, the hepatitis dose, first dose of the hepatitis B vaccine, it has to be administered immediately within 24 hours because that is been seen to protect babies who are born to hepatitis B positive mothers. The other factor which may interfere with the vaccine response is the presence of the maternal antibodies, and they can exert an inhibitory influence up to about 1 year of age. Fourthly, the booster dose. Now we need to give boosters because they tend to increase the immunity to protective levels. So if you give a dose once or twice, you may not achieve the highest immunity, and therefore you need to, or the immunity may wane off. And that is the reason our immunization schedules have booster doses for certain vaccines. Then coming to what is the factor affecting the inclusion of a new vaccine. This could be the disease burden, severity, the mortality, the national security, risk of incorporation, and the competing priorities. So if something is more important for the government, they may not consider giving it at that particular time. They may delay it because of competing priorities. Then the recipient, what is the age, the cohort size, and of course, there's a lot of geopolitics involved in deciding on the inclusion of a new vaccine. So I've heard that now the government has announced that we are going to introduce the HPV vaccine in a programmatic mode for the girls in India. Probably that is more of a political decision right now. Then third is the vaccine. Where do we get the vaccine from? Are we producing the vaccine locally? What is the availability of the vaccine, the cost, efficacy, safety, and if there are other alternative vaccines available? So India has been very lucky in the sense that we have very good and we have one of the largest producers of vaccines in the world. So many of these vaccines are now produced in the country, and therefore the cost has come down drastically. I'm not going to talk much about catch-up immunization because there is a separate lecture on it, but just to introduce the concept of catch-up immunization. It says that if somebody has missed an immunization at the particular time, it doesn't mean that you require to restart the entire schedule. We will give the next dose as and when the patient visits, and the maximum age limit should be followed. So this maximum age limit is important. For example, in the rotavirus vaccine, you cannot give it in the private sector beyond 8 months, and in the government program beyond 1 year of age. So that has to be kept in mind. So if somebody who is 2 years old and the parents come and say that my child did not receive rotavirus vaccine, you say that your time for this is already over and we will not be giving the vaccine at 2 years of age. Then there are also adolescent and adult immunization, which is being talked about, and the recommendations are now available for certain vaccines for all adolescents and adults, and for certain vulnerable age groups and conditions. So that I think also will be a separate talk, so we'll not talk much about it. So that brings me to what are the immunization schedules available to the pediatrician or to the physician. The schedules available for reference are the CDC-ACVIP, Center for Disease Control Advisory Committee on Vaccine and Immunization Practices, which comes from the United States of America. Second is the World Health Organization. Third is the Universal Program of Immunization from the Government of India. And the fourth is the Indian Academy of Pediatrics, ACVIP recommendations. So we need to know, have an idea of all of these so that when you get stuck somewhere, then you can refer to these and take a informed decision. So let me just take you through briefly through the CDC-ACVIP 2025 recommendations. So this is a beautiful way they present the recommendations for use for the pediatrician or the physicians. I'll just take you through here. You see, this is the recommended child and adolescent immunization schedule for ages 18 years or younger, 2025. So they have a chart here of all the vaccines that are given, along with the short form abbreviation and the brand names which are available in the country. So the latest one which has been introduced in this vaccine, the new one for 2025 is the RSV, or the respiratory syncytial virus monoclonal antibody. Then for COVID-19, you see, they have so many options available. For hepatitis A also, they have at least 2 options. So the practicing pediatrician or the physician knows exactly what is available in their country and what are the components. Then you have here, there is a 1, 2, 3, 4, 5, 6 is written out here. The first table, this is actually the table. So this table tells you that means how you determine the recommended vaccine by age. The second table tells you the recommended dose interval for catch-up vaccination. The third one is for the additional recommended vaccines, depending on if the patient has a medical condition or some other conditions indication. Fourth is you review the vaccine types, frequencies, intervals, and consideration for special situations. Fifth is you review the contraindications and precautions of the vaccine types. And the last one will give you an updated review of any new thing which has been added. And then they have given you, if you want to read further, they have a full detail of the website addresses from where you can read that. Along with that, also an indicator for the physician that if you have any reportable vaccine preventable diseases or outbreaks, you're supposed to go to this particular website in the country and report it. And if you have any questions and answers, then they will also have a website for it. And they have a QR code where you can get the online schedule. So this is the schedule, and it's beautifully done. There are 3 colors here, which I'll explain, 3, 4 colors here, which I'll explain to you. And on one side, they have the vaccines written. And then here on this x-axis on the top is the age group up to 18 years of age. So the RSV vaccine, which has been introduced here, can be given anywhere from birth to 6 months of age. So all the yellow ones are the recommended vaccine timings for a particular vaccine. So if you come to IPV, they have the first dose, which comes at 2 months, along with the DPT and the Haemophilus influenzae and the rotavirus. Their schedule starts at 2 months. In our country, we start at 1.5 months. The green is the one, the range of, that means if you have not given hepatitis B ever, then you can give hepatitis B throughout up to 18 years of age. Then the purple is the recommended for high-risk groups or populations. So somebody is immunocompromised, then, or they live in an area where there is a high chance of getting that particular disease. So these are special groups where they will be given the vaccine. And blue is, these are recommended only on clinical decision making, shared clinical decision making. So here they have given a blue for the meningococcal B vaccine. So it means that only if there is an outbreak or they feel that there could be an outbreak, then you take a decision and give the vaccine. And the gray ones are where there is no guidance or it is not applicable. So when you're using this, it is very easy to use once you know what it means. And there are always footnotes available, which also help you if you get stuck. Now, this is the recommended catch-up schedule. I'll not go through it in detail. So they have it right up to so many vaccines are included, including, in fact, the last one is dengue. This is the immunization, child and adolescent immunization schedule by medical indication. So if somebody is pregnant or immunocompromised with CD4 counts, which are of a particular range, if they have a CSF leak, asplenia, complement deficiency, some chronic heart or lung disease, chronic kidney disease or end-stage renal failure, chronic liver disease, and diabetes. So in all of these, you have a recommendation of each of these vaccines. The yellow one, again, is the recommended normal recommendation for the eligible subjects. Red is not recommended. So if somebody is immunocompromised, you will never give a live attenuated vaccine. So this all red for the live attenuated influenza, MMR, and varicella. The brown is recommended if there is an additional dose that may be required. Oranges might be indicated if you feel that there is a protection benefit. And again, gray is no guidance or no indication. The next one is, is the vaccine for adult immunization schedule. So here again, they have, this is above 19 years of age or older. And so here again, they have the list of the vaccines, the brand names, and again, the same way, they have a schedule which will tell you what is to be done and used. So for example, for flu vaccine, you have to give a dose annually. Then for measles, mumps, rubella, if they have not got, then they should get a dose. So this is how it has been recommended for the adults above 19 years of age. And this is if the adults have any particular condition which requires special vaccination. Again, similarly, they have outlined the indications here. So the CDC, I always feel that all of us should go through the CDC guidelines at least once, or maybe refer back time and again when they have a new schedule, because this gives you a lot of clarity on how vaccination schedules are made. And they have been doing it for many years now. Now, there are certain situations when you get stuck and you might have to go and look at the WHO immunization schedule. So this is the immunization schedule. Again, it has all the vaccines outlined on one side with the doses, how many doses are to be given, and the age groups. And they have a small note here telling you on what is, say, for example, polio. The bivalent OPV birth dose is given. And the IPV is actually a fractional dose IPV for the programmatic implementation. So similarly, for rotavirus also, there's a note here which says it's not recommended if more than 24 months old. And they have for the adult immunization also the summary and all these vaccines for certain regions and high-risk populations. And also for the, this is the one for the adults and another one for health caregivers. So what are the ones which we as health caretakers, healthcare workers should be taking? Then also they have a schedule for interrupted or delayed routine immunization. That means the catch-up schedule. And these are all based on summary of WHO position papers, which get reviewed at a regular interval. So these are again for, as I said, for healthcare workers. Then we come to the schedule, which is for the UIP, or the Universal Immunization Program of India, started first in 1978 as the expanded program of immunization, became the UIP in 1985. By 1989 to 90, all the districts were covered in our country. And 2005 onwards, the program is run by the National Health Mission. The target beneficiaries are around 2.6 crore newborns and 3 crore pregnant women every year. And there are about 90 lakh immunization sessions which happen in the country every year, with about 27,000 cold chain points across whole of India. Now, this is the MCP card, which is given. This is from the MCP card, which is given to the babies and the mothers. And this is the immunization schedule, which is there in the MCP card. So here at birth, we have the OPV 0 dose, hepatitis B and BCG. At 1.5 months, we have OPV, Penta, Rota, the first pneumococcal, and IPV first. In 2.5 months, we have the OPV, Penta, and Rota, but we do not have PCV and IPV. The same 1.5 month schedule is again repeated at 3.5 months, with a second dose of PCV and IPV included. Then we straight away jump to 9 months, where the government gives the measles rubella vaccine, the first dose of JE in the endemic regions, vitamin A, and the PCV booster. So I think all of you are familiar with it. And next, from 9 months, they jump to 16 to 24 months when they're given the DPT booster, the second dose of the measles rubella, along with the second dose of JE, and the OPV booster. So you see, there is a scheduling of vaccines. So JE, if we give, I'll show you in the next schedule, the IAP schedule is slightly different. We give it at 1 month's interval. But if you go to the government sector, they give JE at 9 months, and then the second JE is given at 16 to 24 months. So this is how they club all the vaccines together in the program mode, so that the visits are less and you achieve maximum output with minimum visits. Then from 24 months, we jump straight to 5 to 6 years, where we have the DPT booster alone. At 10 years and 16 years, there's a TT booster. And there's a column which is there for other vaccines. For example, in between, they had a measles rubella campaign. So those kind of vaccines will be written here. Or a new area, they introduce, say, the JE vaccine. Then those will be written in this part of the card. Then I come to the last schedule, which is from the Indian Academy of Pediatrics. This is revised every few years and by a committee which sits together. And this is the last schedule which came out in 2023, published in February 2024. So here we have the IAP-ACVIP immunization timetable, which are the vaccines for routine use. On one side, we have the age. The second is the vaccine to be given, second column. And then there are some particular comments for the vaccine. Now, if you read the entire guideline, they've tried to make it similar to the CDC guideline, where they write also some footnotes for each vaccine. And if you read those footnotes, you'll see that they are very concise comments, which clears many doubts regarding the vaccine. So at birth, we start like the government schedule as BCG, OPV, hepatitis B1. And the comment, it says here that the BCG vaccine should be given before discharge, the OPV as soon as possible after birth, and the hepatitis B should be administered within 24 hours of birth, preferably in the first 12 hours. At 6 weeks, we can give either the whole cell or the acellular pertussis containing DTP vaccine, along with IPV, Hib, hepatitis B, rotavirus, and PCV1. So here in the private sector, we have all combined vaccines. So we have the hexavalent vaccines along with rotavirus and PCV1. And there is a note here which is very important, that if the IPV as a part of the hexavalent combination vaccine is unaffordable for the patient, then the infant should be sent to a government facility for primary immunization as per the UIP schedule. So it is better that you send them to the government schedule. So the same schedule continues at 10 weeks and 14 weeks. And here at 14 weeks, you will see a comment is there regarding the hepatitis B vaccine, that an additional 4th dose of the Hep B vaccine is safe and is permitted as a component of a combination vaccine. But 6 months and 7 months, we have the flu 1 and flu 2. And we know now that we are using a uniform dose of 0.5 ml for all anybody who is above 6 months of age. At 6 to 9 months, we have introduced the typhoid conjugate vaccine. Currently, as per the WHO position paper, this is the age that we can give from 6 months onwards, the typhoid conjugate vaccine, and there is no recommendation for a booster dose. They say 1 dose is good enough. At 9 months, we have MMR, the measles, mumps, rubella, in contrast to the government. Then at 12 months, we have hepatitis A vaccine. If here there is a note that if you're using a live attenuated hepatitis A vaccine, then a single dose is enough. At 15 months, we have again the MMR, chickenpox, and PCV booster. At 16 to 18 months, we have the DPT, Hib, and the IPV booster. At 18 to 19 months, we have the second dose of Hep A and varicella. And then we jump straight to 4 to 6 years, where you give the second booster of DTAP or DPT along with IPV and MMR. 9 to 14 years, we have HPV. 10 years, we have Tdap. 15 to 18 years, we have again HPV in 3 doses for those who have missed it. And at 16 to 18 years, there is the TD vaccine. So this actually gives you, and you can make your vaccination cards based on these recommendations from the IAP. At least this is what we follow in the private sector. Along with this, always leave column for additional vaccines, because there are a few vaccines like the JE vaccine, which is given only in endemic areas, and the meningococcal conjugate vaccine, which is given in high-risk population, and it is available in the country. So this is again, as per the CDC mode, they have tried to give you a very good way to show it, that the BCG is a recommended age is here at birth, but you can give it, till up to 1 year of age. And this is for hepatitis B, DPT. And the blue color are the catch-up range. Now, some of the footnotes which are there, for example, with hepatitis A, this is to be given within 24 hours. When this is missed, it can be administered at first contact with the health facility. All stable preterm and low birth weight babies should be administered a birth dose and 3 more doses with the penta and the hexa combination vaccines. An extra dose of Hep B is permitted as per the combination vaccine. IPV can be given as a part of a combination vaccine. If you have the rotavirus vaccine from GSK, which is RV1, then you do not use a 3rd dose. 2 doses are enough. Influenza vaccine should ideally be given in the pre-monsoon period. But at other times, if they come, then you do not deny, you give the most recent strain available. And annual flu vaccination should be continued for all till 5 years of age. For those at high risk of influenza-related complication, annual vaccination should be continued till 18 years and beyond. So if somebody has asthma, which is difficult to control, or cystic fibrosis, those kind of patients, then you will continue. They are the high-risk ones. So you will continue flu beyond 18 years. Then for Hep A, I think I've already told you. Varicella vaccine, a note is there very important, which says that it should be given the second dose should be given 3 to 6 months after the first dose. But if you're doing a catch-up schedule, then in children above 12 years of age, the second dose is to be given after 4 weeks. Tdap should not be administered as a second booster of DPT at 4 to 6 years. Some people used to do that before, so there's a specific guideline that it should not be done, because then you're not giving the adequate component of diphtheria and pertussis toxins. And if you're going a delayed second booster beyond 7 years, then you can use Tdap. Then for 9 to 14 years, the HPV vaccination, all whatever is the quadrivalent and the 9-valent one, are given in a 2-dose schedule 6 months apart. But in those above that age group, you'll have to give 3 doses. The Serum Institute 1 is recommended for females and males between 9 to 26 years of age, and so is Gardasil 9. And Gardasil 4 is licensed up to 45 years of age. So if anybody above 26 years comes, then you can give the Gardasil 4. For 15 years onwards and in the immunocompromised, HPV vaccines are recommended as a 3-dose schedule. Now, Menectra, which is the meningococcal conjugate vaccine, is give 2-dose schedule if the age group is doses should be 3 months. There is a second meningococcal vaccine available from GSK, that is Menvio. This is given in a single-dose schedule above 2 years of age. And for those with ongoing exposure to meningococci, the boosters are recommended every 5 years. And in endemic areas, the JE vaccine is recommended. So this is in a nutshell, the IAP-ACVIP recommendation. Now, just let us look at picture, in a picture form, I want to show you the salient differences between the UIP and the IAP-ACVIP recommendation. So if you see in this schedule, the difference is that we do not give OPV in the private sector, in contrast to the government schedule. And here in our schedule, in the private sector, we have PCV2, IPV2, which is given at the second dose, and PCV3, IPV3 at the third visit, and in between here, at 6 to 9 months, we have flu 1, flu 2, and the typhoid conjugate vaccine. We do not give JE and PCV booster at 9 months. Instead of MR, we use MMR1. And here, if the patient is in a high-risk group or in an endemic zone, then we will also give the first dose of the meningococcal conjugate vaccine. Following that, at 1 year, we have the second dose of meningococcal. The Japanese encephalitis comes in here along with hepatitis A, and along with deworming. And at 13 months, we will give after 1 month the Japanese encephalitis second dose. So for us in the private sector, only 0 dose of OPV is given. IPV and PCV 3 doses along with the DTP, DTAP combinations. MMR is given instead of MR. MCV at 9 months and 2 years. At 1 year. Flu at 6 months, 7 months plus TCV. PCV booster can be delayed up to 1.5 years of age. JE, as I've already said, 12 months and 13 months. And hepatitis A, single dose if you're giving live attenuated, and 2 doses 6 months apart if you're giving a killed vaccine. Coming to the second part, at 15 to 16 months, which is not there in the government sector, we are giving MMR2 and chickenpox 1. At 16 to 24 months, we do not give the MR2, we do not give JE, we give IPV along with DPT and along with HIB. So we give a pentavalent vaccine. Then and also the PCV booster. At 5 years, we give DPT along with IPV booster 2 and MMR 3. At 10 years, we do not use Tdap. We do not use TT, we use Tdap. And we also introduce the human papillomavirus vaccine doses, the first and the second, 6 months apart. Then at 16 years, we will use TD. And those who have missed the HPV, they will be getting 3 doses. So you can use either HPV4 or HPV9. Then any new thing which is there in the future. So there is this news which came out on 1st of February 2024 from the Ministry of Finance that they are planning to take Nari Shakti ahead by introducing the cervical cancer vaccine for girls. And probably they'll be doing it this year. Then Sanofi also received the approval of the RSV vaccine in India. So which means that probably very soon we'll have it available for us. And then the PCV20 from Pfizer is also in the pipeline to be introduced in the country. Now, Someone wanted to know about vaccine brands available in the country. I've just given a brief, just go through it. Nitin, should I go through this or?
Yes, ma'am, please continue.
Okay. We have time, no?
Yes, ma'am.
Okay. So looking at the vaccine brands available in India. So BCG is the oldest vaccine which is available in India right from 1921. It is available as injection, Tubervac, and given dermal, and it is recommended to all infants, healthy infants, including preterm babies. Polio, the oral variety, the oral polio vaccine is available as bivalent polio. We have two oral polios available, one from Bharat Biotech, which comes as biopolio, and the second one comes from Serum Institute of India. The name itself is poliomyelitis vaccine oral, bivalent types 1 and 3. IPV is available in the private sector only as a combination vaccine. We do not have a standalone IPV as of now because of some deficient, there's a less number of IPV available because everybody has taken it up in the government sector. So in the government sector, there is one polio vac, which goes from Serum Institute of India. Hepatitis B vaccine, a number of them are available. The oldest one, which we were using initially, and I think that was Engerix B. And we have Genivac B from Serum Institute. From Bharat Biotech, we have Revac B. The Revac B is thiomersal free, so it's supposed to be better. Then from Biological E, you have BVAC. The cost is very less, so I think just may cost around 30, 40, maybe 50 rupees. Now, there are a lot of combination vaccines available, the DTWP and DTAP. They're available only as combination. Most of them are available as combination vaccines. So in hexavalent, where you have the DT wholesale along with IPV, Hib, and Heb, this comes as EZ6 from Panacea and Hexacil from Serum Institute. Hexacil will be nearly about 4,000 rupees, but EZ6 is around 2,800. The DTAP, IPV, Hib, and Hep B comes also as Hexacin from Sanofi and Infantrix Hexa from GSK. Pentavalent, we have Pentavac from Serum Institute, the wholesale one, along with IPV and Hib, and EZ5 from Panacea. And the acellular one with IPV and Hib comes as Pentaxim from Sanofi. Quadrivalent vaccines, we have Tetraxim from Sanofi, DTAP, and IPV, and DTWP and Hib, which comes as Quadrovac from Serum Institute, and EZ4 from Panacea. So it is important to know all of them because here you can give a choice between DTWP and DTAP combination vaccines to the patients. There's a difference in the cost in this. The pentavalent vaccine, for example, the Pentaxim is useful when the Pentavac is useful when you need to do the 1.5 years vaccination, the boosters. The quadrivalent Tetraxim from Sanofi, I use it at 5 years of age because then we can give DTAP plus IPV because the DTWP plus IPV is not available separately. And this DTWP plus Hib, in some situations, I hardly write it. So some people do use it. Then we come to the Tdap and TD. Tdap comes as two brands, Boostrix from GSK and Adacel from Sanofi. I think currently now only Boostrix is available. TD is made by two companies, BE and Serum Institute of India. PCV, there are at least 3 brands which are regularly used. The one from Synflorix from GSK, I think nobody is using now. We have from Serum Institute, the Pneumocil PCV10 made as per the strains prevalent in our country. Then we have additional one which has been introduced by BE, the new BVAX 14. This comes as new BVAX 14 from BE. The same vaccine is marketed by Abbott as Pneumoshield. So the components are the same. Then the Pfizer we know has Prevnar 13 and probably very soon they will be introducing the Prevnar 20. Then there are many other companies which have come up. I don't remember the names offhand. For the pneumococcal polysaccharide vaccine, we have MSD, which is there for a long time. It comes as Pneumovax 23. The same vaccine is marketed by Lupin as Nucovax 23. Rotavirus, we have one from GSK RB1 Rotarix. From Serum Institute, this is Rotavirus 5, this is Rotacil. Bharat Biotech has the 1160 strain made vaccine. The original one came as Rotavac, and then they have Rotavac 5D. So Rotavac 5D means 5 drops. And we have one from MSD, which is Rotatech. So cost of all of these are nearly the same, around 900 rupees for a vaccine. MMR comes as Tresivac and Priorix. Tresivac is from Serum Institute, around 700 rupees or 650, and Priorix is slightly costly, which is from GSK. MR vaccine, we have from Serum Institute, which is supplied to the government, the MR vac. Varicella, we have quite a number of them. So from GSK, one of the oldest one is Varilix. The one which is commonly used these days, available freely, is MSD Variped. Wockhardt has one, BioVac V. Novo has come up with Nexipox. VHB has Varivax, and Juventus also has one called Zuvicella. I have only used the first 4. So Varivax, I remember using once, and then it went out. I mean, nobody comes to sell it. For hepatitis A, we have the killed and the live attenuated. Live attenuated, we have only one, BioVac A from Wockhardt. So single doses to be given, subcutaneous. For the killed, we have from GSK, Havrix 720. B, we have Happy BV. The same Happy BV is marketed as HapShield by Abbott. And then from Human Biologicals, recently they have come out with HaviSure. Typhoid conjugate, I think the first one was from Bharat Biotech, TCV. The same one is marketed as EnteroShield by Abbott. B has one more, Typhi-BEV. Niomed has Pedatype. Zyvac also has one, Zyvac TCV, from Cadila Healthcare. And then Sanofi used to have one called Typhim-VI, but I don't see it available currently. Flu, we have at least 4 companies. Influvac Tetra from Abbott, Flu Quadri from Sanofi, Zydus Cadila gives Vaxiflu 4, and GSK Bliss Fluarix Tetra. Cost of all of these are nearly in about 2,000 to 2,300, depending on which brand you are using. Now, JE vaccine is one which has been running in the government program by the live attenuated cell culture SA 1414-2, comes from China, and it is used only in the government program. In the inactivated SA 1414-2, which is available, internationally, it comes as EAC0, but in India, it is marketed as JEEV by Biological Events. The inactivated Verocell-derived polar strain is the one produced by Bharat Biotech, comes with the brand name of Genvac, around 750 rupees cost. The live attenuated SA 1414-2 chimeric vaccine, this is not available in India. It comes as IMOG, and it is manufactured by Sanofi. Worldwide, if you look at the literature of all JE vaccines, IMOGEF has the one which has the highest studies being done and efficacy being shown for a long time. So it is quite a good vaccine, but this is not available in India. So in India, we have GEV and Genvac for use. HPV vaccine, the first one was Cervarix bivalent from GSK. It is no longer in use. We have quadrivalent, 2 companies, Gardasil from MSD and Cervavac from Serum Institute of India. There's a huge cost difference between these two. MSD one comes at nearly 4,000 rupees, whereas Cervavac is at 2,000 per dose. The 9-valent one, which is Gardasil 9, is available for use, and the only issue with the 9-valent one, it is quite costly, nearly 10,800 rupees to the patient. Meningococcal vaccine, we have the ACWY CRM from GSK, which comes as Menvio. Then ACWY DT Menactra from Sanofi. Both are equally efficacious. Only thing is Menactra can be used from 9 months of age, but the GSK one is from 2 years and above. Men-Afri-A, produced by Serum Institute of India, is licensed for use only in Africa. And interestingly, they are now manufacturing the Men-5 by Serum Institute, which includes ACWY-X And this has achieved WHO pre-qualification, and again, only being produced for Africa currently. So they had to produce this MEN5 because when they were using MEN-FE-VAC for a long, long time, they found that there was a serotype conversion in Africa, leading to more incidence of the other serotypes. So now, therefore, MEN5 is the one which is being given there. Herpes zoster vaccine, it's a recombinant varicella zoster virus, available as Shingrix, GSK, 2 doses, 2 to 6 months apart, IM. I'm told it is quite painful. Yellow fever vaccine comes as Stamaril from Sanofi. And one has to note that it is available only in government-approved vaccination centers, including a few airports. It is given as a single dose, subcutaneous or IM, and above 9 months of age. Now, this is the yellow fever endemic country list updated by WHO. So if anybody is going to Africa, they need to take it. And in Central and South America, if you're going to Brazil, Colombia, and all these, Peru, then you'll have to take this yellow fever vaccine. Single dose gives you 100% protection. Now, this is the yellow fever vaccination centers by the government of India. I've just showed you the first list where it comes state-wise. So if any of your patients plan to go outside, before, till last year, we were also able to give the vaccine. But some incidences happened where patients were not given the vaccine and they were given a false certificate and all that kind of thing. So the government has made it very strict because they don't want this disease to be imported to the country. So you see, I'll just show you for Andhra Pradesh, there is one center here at Port Health Organization, Vishakhapatnam, and Government General Hospital, Siddhartha Medical College, Vijayawada. Then I come to Assam. Assam, we have only one center. In fact, this is for the whole of Northeast. This is being made available at AIIMS Guwahati. So if we need to do, and then, it's very nice because they have the Google map out there where the patient can follow the Google map and visit these centers. And the registration details and vaccination timings are also given along with the contact details of the persons responsible. This is just one page. And there's a whole list up to, I think, 69 centers available in the country. So this you can refer to when you have to advise somebody about the yellow fever vaccination in our country. Rabies, there are quite a few of them, just naming a few. We have the human-derived Abhairab from Human Biologicals and Rebivax S from Serum Institute. Virocell-derived is Indirab from Bharat Biotech and Chikungunya is Rabipur Novartis. Some just to touch, because this has not been touched in the vaccine schedule, what are the rabies virus vaccine recommendation? So it is said that if you have a pre-exposure prophylaxis, for example, somebody is keeping dogs at home or you're exposed during working in a laboratory, ideally you should get a pre-exposure prophylaxis, full dose IM on day 0, 7, third dose anytime between day 21 and 28. I think IAP needs to push for this universally in all children. The second is the post-exposure prophylaxis. So if you have not been vaccinated, then you do one-site IM on day 0, 3, 7, and between 14 to 28 days, total of 4 doses. This is the SN regimen. There are some other regimens also, but this is easy to remember. But if suppose somebody has received a pre-exposure prophylaxis or a post-exposure prophylaxis within the last 3 months, then that patient does not require any additional PEP for a second bite. But in those who have received it more than 3 months ago, then we will give 2 doses IM on day 0 and day 3. So this is quite different from what was being followed for many, many years. And no monoclonal antibody or immunoglobulin is needed if somebody has received a pre-exposure prophylaxis or a previous post-exposure prophylaxis. The other products which are there for rabies are the rabies monoclonal antibodies recommended for category 3 severe bites, where we do a local wound infiltration. So we have 2 products available, Rabishield from Serum Institute. The dose is 3.33 international units per kg, and Twinrab from Zydus, which is at 40 international units per kg. This can be given within 7 days of a bite. The earlier, the better, but you can give it even up to 7 days. Hepatitis B immunoglobulin for babies born to Hep B positive mothers. And this is available from three companies, Heparel, Hepa-BSV, and Hep B immunoglobulin. So this is all about the vaccination schedule. In conclusion, I think I'd like to wind up by saying that awareness of all the available schedules is important because it helps you to get out of a tricky situation if you're confronted many a times. The caregivers must always be given the knowledge about the available vaccines beyond the universal immunization practice. So you have to tell them that, see, there is a typhoid vaccine available, there is a chickenpox vaccine available. It is not there in the government sector, but we can give it to you, and this is the cost. And therefore, you need to do a one-to-one discussion on the available vaccines, the benefits, cost, and the side effects. So for further reading, I think these are very good books which the IAP has taken out. The latest one, which is the purple book, the IAP Guidebook on Immunization 2022. If you've not got it, it is available online. And if you're an IAP member, you can log in to the IAP website and access this PDF copy of this particular book. The IAP textbook of vaccines is another very nice book with a foreword written by Stanley A. Plotkin, which is the father of vaccination. Then we have the IAP guidebook on immunization as well as the frequently asked questions. So if you have all these four with you, I think many of your vaccine problems and questions arising out of it will be solved. So vaccine saves lives. So let us work for it. Thank you very much for a patient hearing. And I'll take up some questions if there are any.
Thank you, ma'am, for being a wonderful teacher once again. I'll start with my first question, ma'am. There is Dr. Gaurav who asks if when should we, if CDC is when to be used when IAP-ACVIP is available.
See, CDC, you get stuck sometimes. It's now because the IAP-ACVIP is updating every day, we really don't need to use the CDC. But suppose you have, say, the RSV vaccine becomes available in the country, but IAP has not given you a recommendation. And then you have someone coming from outside saying that, okay, my child was born there, but we came here and I need to take the RSV vaccine. Then you will have to fall back on the CDC guidelines. The same thing happened when I had to give the Gardasil to my sons. At that time, there was no recommendation for a Gardasil for boys. But I thought that it was a good vaccine and the boys needed it equally. So I fell back on the CDC guidelines where it was clearly written that it was recommended for both boys and girls.
Second question is regarding HPV vaccination. How many doses? Schedule at 9 to 13 years first dose and next after 6 months. If not 2 doses before 13 year, then 3 doses. Those who have not received a single dose, then what about them? What is the maximum age they can be vaccinated and how many doses?
This all is for HPV only?
Yes, ma'am.
Okay.
I think you have already covered it. And
I've covered it. It's 9,
yeah.
9 to 15 and above 15.
Yeah, and Dr. Mansoor, I will also share one pager flyer which gives abundant of information, and that will also reinforce what my ma'am has posted. Ma'am, you have already covered this question in your talk as well. And
Yeah,
Dr. Jaya
fractional,
asked that,
there is a
yeah,
question on fractional IPV.
yes,
So fractional IPV is also given at 9 months. This is the government schedule, UIP. Okay.
yeah, in Karnataka only he has
In
mentioned.
Karnataka. And now they're saying that even for the government, they will probably do off with the fractional IVP and give the full dose IVP.
Okay.
Okay. And JE not added. JE not added. I don't know what he wanted, Dr.
I
Sandeep.
think it's a comment. He just added a comment. And from Dr. Jaya asks, is till 3.5-year-old child has received all government vaccine. Next, what are the vaccine to be given as per IAP? Can we advise Hep A, typhoid, varicella, MMR in single visit?
Yeah, we can. Whatever vaccines the child has not taken, say, for example, they not got the flu, the typhoid, chickenpox, you can start giving those. And you can give all of them at a single visit, depending if they're able to pay you for it. There is no such thing. And then you should just finish the schedule as per, the gap given.
Another is if father is Hep B positive, mother is negative, any prophylaxis for child newborn?
No prophylaxis. You give the 0 dose. May ensure
Child,
that this hepatitis B first dose is given within 24 hours.
Child has taken MR from government at 9 months, later shifted to private sector, so we can continue on MMR.
Yes, we can continue. We should continue. And in the WhatsApp group, there was one question about MMR and MR. Child has received 2 doses of MR, and should we give MMR and how many doses? See, we are giving, there is no problem with giving extra doses of measles, because we know that the measles immunity is, it is not very good, robust. Therefore, we need to give multiple doses. But for mumps and rubella, 2 doses are enough. So if you're giving MMR, like for example, MR from the government, explain it to them that you're giving the MMR for the mumps, and here you will need to give 2 doses.
Meningococcal, if already followed government schedule in a normal child. So child has not received meningococcal till now. I think that is the question which Dr.
Yeah.
Anjali
So
want to ask.
if your child is, say, at 9 months of age or below 1 year, you'll give 2 doses. But if child is above 2 years, then you get single dose given.
Ma'am, this concept of 2 versus 1 is basically because it's a conjugate vaccine, immunity will be better
Yes.
after 2 years.
Yeah, this thing is, if see the Menectra, which is from Sanofi, is the studies were done in India from 9 months of age. In US and all, they use it even earlier. Like
Okay.
some of the countries like UK and all, they're giving MCV even at along with the DPT because of the epidemiological studies they have done there. But in our country, since we have from 9 months, you can give as early as 9 months because these are a vulnerable group. And if you give at 9 months, you need to boost this up by giving a second dose at after 3 months. But if you're using a dose after 2 years of age, then you will give a single dose, which is good enough because of the conjugate vaccine.
If patient has taken IM dose of rabies vaccine for post-exposure prophylaxis for first 2 day dose and has come to government hospital for rest of dose, how to proceed? IM or intradermal?
IM. If it is IM, then you should continue with IM. Intradermal, I don't think so. It is being used even in the government. They're giving in India. I mean, I may be corrected, but as far as I'm aware, they're using all IM only.
Yes. Ma'am, if child receives MCV less than 3 months apart within 2 years, what to do? Nothing.
I think that question we have already answered. They've
Yeah.
adequately covered. If this child is in continued exposure, that means it stays in an area where the meningococcal, epidemic may occur. Say, for example, in Delhi, in Northeast, then you will need to boost their immunity every 5 years. Or if the child has a complement deficiency or a CSF rhinorrhea, then that patient will require repeated doses.
Ma'am, if child has taken Gardasil for 2 doses, now planning to take Gardasil 9, what is the schedule?
You give 2 doses, 6 months apart, if you want to cover all the strains.
If someone has received Gardasil 4 and now they are insisting that give me Gardasil 9, so we consider Gardasil 9 first dose on 6 months, and after
Yeah.
6 months we consider it a second dose.
Second dose. Yeah.
Ma'am, I have a doubt about this 15-year or 14-year as demarcation. Is it related to menses or is it related to age, or why 9 to 14 and after 14?
Yeah, because I think this is related mostly to sexual exposure in
Okay.
the West.
And in India, although there is increment in adolescent pregnancies also, but sexual activity in adolescent in urban India and where rural India are different. But this, if the child is having menses at around 10 or 11 year, is it still 2 doses?
Two
In
doses.
2
It is
doses.
not related to the menses. It's mostly to the
Okay.
sexual activity.
Sexual activity.
Yeah,
Okay.
the first sexual activity
Okay.
exposure.
Can brands of vaccine be changed subject to availability?
As far as possible, Sumana, don't change vaccine brands. But if they're absolutely not available, then it's a different thing.
Any specific reason for this?
It is dependent on the component, the adjuvant, and everything is different, no, for each vaccine. So that's the reason they say that try not to change. Now, in case, I'll just give a different example. For example, if you use EZ6, the components of the diphtheria, pertussis are different here. And then you just want to add another one, say you want to boost it with something else, then it becomes difficult because you're not getting the same immune response. There is a question of mumps vaccine, a single vaccine. No, I'm not aware.
No.
I searched. There is not available.
For catch-up vaccine, is it okay to give vaccine on same day, or is there an issue of simultaneous administration? Cost is no issue.
No, you can give it on the same day. I think we already covered. There's a
I
single.
personally feel nowadays urban parents are worried about one injection, so giving two at a time is more than
No,
enough.
there are two kinds of parents. One is the parent who is worried about the child getting even a single shot, so they want to avoid the others. The other parent is worried about whether they'll get the time to come back or not, so they insist you give everything together. So there are two
Yeah,
kinds
true,
of
ma'am.
parents. And there's one question here, Ahmedullah. Single dose of varicella, is it enough at 15 months? No, varicella never single dose. You have to always give 2 doses of varicella for good immunity.
And one question by Dr. Banani: if child has received Menectra by 1 year, first dose 9 months, and then second dose after 1 month instead of 3 months, how to follow it up, ma'am? And the two doses before 1 year has been given, 9 and 10 months rather than 9 and 13, 9 and 12.
Then that immune response will not be adequate, you know. You will probably have
Ma-
to give another one after
2 years will be better, but I think the real question here is if it has been given, should it be informed to parent and discuss the plan, or you just give
yes.
it after
No,
two
no,
years?
I think we should discuss. Yeah, this is a very costly vaccine.
Yes.
No?
Yeah.
Then you see if
And
child had 3 doses of Acha, that I've already answered.
yeah, and the recommended gap is 3 months. Okay.
Mm.
Um, when should birth doses given to extreme preterm? I think we will be covering it in next
Yes,
session
yes.
in preterm delivery and the chicken. Well, will second dose be effective? Or Dr. Banani has got her answers.
Mm.
Uh, so here's a thank you. MMR and varicella to be given together or for how many days apart, ma'am?
No, they're given up. They're given together.
Yeah.
At 15 to 16 months, you give MMR and chickenpox. On one side, you give MMR. On the other leg, you give chickenpox. Initially, GSK used to have the combination vaccine.
Combined.
So yeah, but
Attract.
it's not
Yeah.
available. Prior
Very.
extra,
Yeah.
but it's not
Paris Tetra.
available.
They stopped it immediately. I don't know why.
Yeah,
It would have
some
been a
issues.
good one. Yes. Vitamin A not given in private. Why?
No, no, no. It's not that you don't give it. You can give it. It's only that
Yeah.
it's not there in the schedule.
Yeah.
Yeah, but you can give it.
So Dr. Manish has actually taken my question. I wanted to ask: is 2+1 PCV taken in government will give PCV booster at 18 months?
If you ask me, yes, because this 3 doses in the private sector, we are saying we have to give at least 4 doses. So you can give another dose at 18 months. And we know that the government is using mostly either Pneumocil or Pneumovax, so we can give it.
So, ma'am, there was one question today at our center on discussion was that the patient has come at 6 weeks. They have got one PCV, 12, 18 weeks, 10 weeks, 14 weeks. 6 and 14 is government of Telangana gives that. So they wanted 10 weeks of vaccine at pneumococcal. So should we recommend that 6, 10, 14, 6 and 14 from government, 10th week at our private
Yes,
setup?
yes.
Yeah,
There are
yeah,
some parents who do that. We know that the government is giving PCV 10. I
yeah.
think they're giving PCV 10, so you can give the PCV 10
13.
is
10
Pneumocil.
over here also.
Yeah,
Okay.
yeah, yeah.
Dr. Sumanna has actually helped us in telling the reactogenicity
Yeah.
was high. That was prior tetra was stopped. So Subham mentioned that if a patient is 2 year in vaccination, is naive with only bird dose of vaccine and is exposed to varicella and present for immunization within 3 days of exposure, what vaccines to be given?
Uh,
Basically, he wants to say that if viral immunity levels have gone down, should we vaccinate? Ask them to come
yes.
after 10
Yes.
days.
Even if they come within 3 days of exposure, you can give the vaccine. It may not work that well, but it is going to reduce the uh, like the
Efficiency.
severity. Yeah.
If you have immunoglobulin, how long after to give live vax? Okay, I don't know the question. If a child has received PCV 10 or 13, should we give PCV 20? PCV 20 is not for pediatric age group. It is
Mm.
recommended and approved only in adult, and that too not
Yes.
present right now in India.
Right now, yes.
Ma'am, is it still recommended to give varicella vaccine to child who has documented varicella infection before 15 months of age, since it is said to be infection? This infection give lifelong immunity.
I think she's answered her own question. That is true for chickenpox and for hepatitis A. Yeah. What about
Sandeep.
the vaccines which are missed?
So Sandeep says, if by chance due to our vaccine advice on vaccination, patient is following our advice, and in future if he gets any disease, are we medico legally bound for any action? So
No, we are not bound because as per your recommended schedule, you have given all the vaccines. You have the backup of these 3 or 4 guidelines which I've shown you. Because you have to explain to them that the vaccines are for optimal immunogenicity,
yes,
not for perfect or complete immunogenicity. Okay. And there are many other factors which come into play. For example, the immune system itself, the environment. So there are a lot of biases which come in. So therefore, we are not legally responsible. There's in here, I like this question for the reason that I'd like to tell one thing, that suppose you have, say, it is not recommended by IAP to give MCV, and meningococcal vaccine is to be given only to the high risk groups or special situations. But still you let the patient know that this vaccine is available. And you write down that this vaccine availability has been explained, because say sometimes it happens that patient may get meningococcal, then the patient may catch you that why you did not tell me that this vaccine was available. It has happened with pneumococcal vaccine. I've heard 2 or 3 incidences. So that is a legal point which you should be careful of. And you said that vaccine is available, explained. Something you should write it on the paper.
as a dictum, I can add something in here, because
Yes.
medico legally, to make our practice safer and better, make
Mm.
sure that whenever you give vaccine for the first time, like for 6 weeks, the child is coming to you, ensure to tell them that this is the first time a biological product has been injected. Keep a watch on reactions. At the same time, mention that no vaccine gives you 100% protection. It is not that after vaccination you can walk in a room and saying I will not get infected. Chances of your immunity to work for you will be better, but this is an informed decision by the parent. And in, like you said, mentioning it, that risk factors explained, risk of vaccination and associated factors explained, should be there in one of your paper, preferably in every vaccination schedule. You should mention. And if you have a printed OPD sheets, then mention that vaccination are biological products, meant to inform whom to inform in case of allergy and other things. This keeps your practice safer and better.
Yes, agreed.
uh,
Dr. Varun has a very interesting question. Post varicella, lifelong immunity is present. So why is zoster vaccine recommended later on in life? The reason being because zoster they have zoster or shingles because of the dormant virus which is there. So to handle that, actually you need the varicella vaccine doesn't work for that. So you need to give the zoster vaccine for that. I think individual vaccines, if we discuss, it'll be better, no, to give.
Yes, ma'am. Actually, we have already discussed this very question, Shingrix versus Viral on the group, and I'll share with Dr. Varun again and
Yeah,
then it
yeah.
was a good and extensive discussion. I'll share it with him. Dr. Bidisha asks, if TCV not given at 6 to 9 months, can TCV given till 2 year of age?
TCV can be given till any years of age up to 45 years.
Yes. Uh, there is one question. If you have immunoglobulin, for example, in Kawasaki disease, how long after to give live vaccines?
I initially it was about 6 months, but I will have to look back. I think the recent recommendations are you need to give a gap of around
4 weeks.
3 months. I'll just confirm it. I'll post it in the group.
Okay.
Okay.
We are done for with the questions, but I am very sure that we will have ample of questions. कुछ तो मैं ही add कर दूंगा, but it is a privilege, ma'am, to have you. And there is one last question. Vasudha has asked, TCV single dose or 2 doses? So
WHO says single dose is enough,
Mm.
but in an individual one-to-one basis, if you feel, you can always give 2 doses.
There is something being discussed that after 3 years TCV should be given as a booster, ma'am. What is your personal opinion on this?
I do give
Okay.
personally, because even for Genvac, they said the single dose is enough, but I am very scared of leaving a child like that with a single dose.
Mhm.
Yeah.
If HPV schedule get interrupted because of pregnancy, how to complete the schedule post delivery?
Immediately in the immediate perinatal period, you can the mother can come and take the remaining doses.
Ma'am, as a practice, do you also tell your patient with infants who are coming 26, 28-year-old mother, do you also as a pediatrician are involving in adult vaccination, or you are leaving that forte for? Because I have been approached by many parents because they I have more trust on pediatricians for vaccination per se, although not for HPV per se, because they are coming for Prevnar, Shingrix, they are reaching out to me, but I felt that keeping a board of HPV about HPV vaccine and how it is useful till 45 and till 26 year of age, because Gardasil 9 as per US and as per insert in the vaccination vial, it clearly says that Gardasil 9 can be given till 45 years in female, but only till 26 year in male. So these are the two things which have been printed and which been kept, and I have found it personally very helpful to counsel in the practice while in OPD practice. Parents are happy with content and they don't decide on a costly vaccine immediately. They get lot of information, lot of robust data from relevant vaccine companies. Also, there is a flyer. MSD is doing a lot of work on that. So, do you also think it is a useful way of telling and making them a healthy choice?
Yes, yes. I also get a lot of adults who come into me for their flu and pneumococcal. And also if they travel outside, we have the adolescents and the young adults, they do come to me. Even the flyer and the standees from MSD are helpful enough because the parents read and then they ask you, So I have a lot of
Mm.
women also who have taken HPV
Yes,
from me. So I think we are the best persons to give because we have the maximum experience.
yes,
And we should always encourage adult vaccination. Start with yourself. I have taken everything. I take flu every year. So I
and me
tell
too.
them, even for HPV, I have taken. So I get the confidence of telling them that, see, I have taken, nothing has happened to me. So it's going to be, there's a lot of misconception about HPV still existing now. Something to do
Absolutely.
with fertility and
Yeah.
menstruation, all that. So
One question from Shubham. I think we'll take this as the last question, and then we'll take all the questions on the group. So Shubham is asking that if the child has taken only birth vaccine and after varicella, what all vaccines should be given within 3 days of
uh,
exposure?
what all vaccines within 3 days of
Hmm.
exposure? No, you want to give, you can give all the vaccines, whatever is due and whatever the patients can afford. This is nothing to do with the varicella exposure. The only thing varicella exposure is the varicella vaccine itself for that
Hmm.
particular, situation. There is one more question, which HPV help on active wards? Yes, it helps. In fact, this is supported by gynecologists. I have heard a lot of gynecologists saying that nothing worked. When they give the vaccine, the wards disappeared. Which is the best month to get the annual flu booster? Pre-monsoon.
Yep.
But having said that, it doesn't mean that if the child doesn't, it comes in the winters, you don't give the vaccine. You give whatever the latest is available, use the opportunity to vaccinate with the
Right.
flu vaccine. Yeah.
Okay. Thank you,
Fine.
ma'am. Yes, ma'am. Fine.
Yeah.
Thank you for
Thank you very much.
giving all the time, and thank you everyone for participating with all your heart and soul. Please put all the questions on the group. I think many will learn from all this discussion.
Yeah. Sure.
Thanks a lot, ma'am.
Thank you very much for inviting me. Thank you.
Take care, ma'am.
Bye.
Bye.